It's a pleasure to be with you. The title of this talk is Leadership and Management, Coalition Building Concepts. There are no disclosures for this presentation. Objectives include review how coalition building relates to the community engagement continuum, review key team building, boundary spanning, and community engagement concepts as they apply to coalition building. Discuss how coalition building is related to integration. Discuss the importance of cultural competence for effective coalition building. Review how to build coalition cohesion. Review the 6 attributes of coalition effectiveness, and discuss how coalition building relates to the 10 essential public health services. There are 3 major sets of tools to change risky behaviors: policy, influencing an individual one-on-one, the clinical approach, and population-based interventions. Policy is developed by local, state, and federal governments, businesses, and organizations, and is an effective tool to encourage healthy behaviors, but must be implemented and enforced. Clinicians are trained in one-on-one counseling, another powerful strategy to change risky behaviors. Population-based interventions provide another potent behavioral impact and can be divided into 2 major tool subsets: social marketing and community engagement. Coalition building is often an essential part of community engagement. Population-based expertise lies in the discipline of public health. Coordination between policy, clinical, and public health stakeholders and interventions is essential to adequately change risky behaviors. This will require effective coalitions working together across these and other silos. Public health leaders are well positioned to facilitate the development of effective coalitions at the national, state, and local levels. It is extremely important to adequately fund public health to provide these services. Increased public health investments, especially in low-resource communities, has been associated with decreased mortality from preventable causes of death, including those associated with infant mortality rates and deaths due to cardiovascular disease, diabetes, and cancer. For each 10% increase in local public health spending, mortality rates fell between 1.1 and 6.9%. This underlines the importance of effective advocacy strategies to adequately fund public health at the federal, state, and local levels. This slide reviews what I call the community engagement continuum. Community coercion is located at the left of the slide. This is where things are done to and for people. Community engagement is on the right side of the slide. This is where things are done with people. In between, we find consultations and building of partnerships and coalitions. The closer a program gets to the right side of the chart, the more community ownership and true engagement. The Centers for Disease Control and Prevention, in their book titled Community Engagement, define community engagement as the process of working collaboratively with and through groups of people affiliated by geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. It is a powerful vehicle for bringing about environmental and behavioral changes that will improve the health of the community and its members. It often involves partnerships and coalitions that help mobilize resources and influence systems, change relationships among partners, and serve as catalysts for changing policies, programs, and practices. Coalitions can be defined as a union of people and organizations working to influence outcomes on a specific problem. Coalitions accomplish more through collaborative efforts than individual organizations working separately. It's important to note that coalition building is not the same as community engagement, but can be a part of community engagement. The term community engagement is often misused. Much work in the name of community engagement is actually community coercion, where external experts gather and analyze community data, design a response, apply for a grant, and if funded, attempt to sell the project to the community. This is not community engagement, but community coercion. Webster defines coercion as the use of physical or moral force to compel to act or assent. Community coercion rarely, if ever, results in community ownership. True community engagement is the facilitation of communities to own their problems and solutions. Good coalition building uses many concepts of true community engagement. The CDC states that engaging a community is ultimately about facilitating community-driven action. That community action includes effective coalition building. Hatcher defined 4 constituency and community engagement development practice elements, including 1. Know the community, its constituents, and its capabilities. 2. Establish positions and strategies that guide interactions with constituents. These first 2 elements translate into a facilitator spending significant time with community members to develop relationships, to understand their perceived needs, and determine if the community is a reasonable candidate for a community engagement or coalition building process. 3. Build and sustain formal and informal networks to maintain relationships, communicate messages, and leverage resources. Engaging informal networks and their informal leaders are extremely important in community engagement and coalition building. 4. Mobilize, engage, and empower communities and constituencies for decision-making and social action. Communities and their members hold all the cards in a true community engagement and coalition building process. The community will determine its priorities based on their perceived needs and will make decisions focusing on those priorities, not necessarily those of external partners or experts. Much of the work of community engagement and effective coalition building revolves around the development and maintenance of relationship strength and trust between the facilitator, informal and formal community leaders, community coalition members, and community members. True community engagement and coalition building is facilitation of a process of problem solving within a community versus the application of a project to a community. It's doing something with, not to or for, a community. A coalition must own the process from the beginning, even determining whether there will be a coalition. This is true ownership. This approach doesn't fit current grant processes very well with their rigid schedules and guidance. Grants often undermine local ownership. An Institute of Medicine IOM report in 2012 focused on the need for increased true integration of public health and primary care to adequately address the goals of decreasing risky behaviors in the population. Even though this report focused on the integration of public health and primary care. The concept of increasing integration across other silos applies to the work of public health in general. The IOM committee identified 3 attributes associated with effective integration, which also applies to effective coalitions. 1. Groups must have a shared goal. 2. Groups must have a willingness and ability to contribute to that goal. 3. Participating groups must commit to an ongoing process. Coalition building can't be accomplished with one or a few meetings. Problems addressed by coalitions are often complex and adaptive, requiring regular, multiple meetings over a fairly long period of time to solve problems and implement solutions. One of the most used diagrams from that 2012 IOM report is adapted on this slide. There is a continuum of integration from isolation to merger. In between those poles rest awareness, coordination, collaboration, and partnerships. Isolation means that groups have no idea what others are doing. Awareness means that groups are cognizant of others working in common areas of interest but have no engagement between groups. Coordination, collaboration, and partnerships are defined as increasing levels of working together. Also, as one moves from the left pole of isolation to merger, there's increasing dependence or interdependence of groups on each other. Merger is the state of total immersion and fusion. Isolation and merger are relatively uncommon. Most experts feel that much of what is done currently in integration falls into awareness and coordination with too little true collaboration and partnerships. Collaboration and partnerships can also be defined as effective coalitions, as diagrammed. The Institute of Medicine strongly recommended that increased collaboration and partnerships, or the development of effective coalitions, are needed to adequately address future health and wellness goals. Collaboration and partnerships don't just happen. They're created utilizing coalition building, team building, and boundary spanning skills and competencies. The goal of team building, boundary spanning, and coalition building is to facilitate groups to effectively work together toward common goals. Therefore, these 3 sets of skills and competencies possess many similar concepts and techniques. In this talk, I will focus on basic coalition building ideas. Unique team building and boundary spanning skills and competencies are discussed in other sessions of the North Dakota Public Health Training Network. Coalitions are composed of partners. These partners may represent internal and external groups and organizations to a target community or area. The most effective coalitions are those that contain strong organizations from the target community, comprised of community members, commonly including formal and informal community leaders. The diagram on this slide demonstrates a hypothetical community Healthy Heart Coalition. There is strong community organization membership, including 2 community clinics, the Chamber of Commerce representing the business community, and the local faith-based consortium. External partners include the State Health Department and the Regional American Heart Association. As mentioned previously, coalitions don't just happen. Someone needs to take the lead to form and facilitate them. This is often the role for public health leaders. Public health is often considered a neutral party, especially when there's competition between coalition members. Let's assume, in this hypothetical example, between Clinic 1 and Clinic 2. This neutral status is essential for effective facilitation of multiple partners. During my tenure as state health officer, the health department, as a neutral facilitator, was able to develop a statewide coalition called Healthy North Dakota. The coalition was composed of multiple programs from various agencies, healthcare organizations, nonprofits, etc., interested in working together toward common goals of improving the health and wellness of the state. The State Department of Health was the only organization that could organize and facilitate that coalition. Let's review a few basic community engagement concepts that apply to effective coalition building, including the role and threat of external funding, cultural beliefs and intolerance, cross-cultural communications, building cross-cultural cohesion, cultural change and resistance, perceived needs and real needs, and group participatory techniques. Let's start with the role and threat of external funding. This is a quote from the National Institute of Health book, Principles of Community Engagement, 2nd edition. Although it is essential to begin by using existing resources, the literature on capacity building and coalitions stresses that engagement is more likely to be sustained when new resources and capacities are developed. External funding, the new resources and capacities in the quote, can be a positive or negative influence on community engagement and coalition efficacy. External funds, often in the form of grants, are commonly associated with the external funder's agenda. Those external funds and agenda can move coalitions to powerful positions within the community, often pushing an external agenda which may not be aligned with the community's agenda or priority. In a situation like this, coalitions and their work can undermine the community priorities. A major concept of community engagement is that with or without external funding, community ownership of the whole process is extremely important. External agendas should never trump community priorities and agendas. External funds bring a threat of external control, so be careful when seeking external funding for coalitions. During our work in Uganda, we helped facilitate a community engagement program in the Ruwenzori Mountains of western Uganda. The program was very successful and fully dependent on local resources within the participating communities, making it sustainable. Health parameters improved in the area. An external nonprofit noted the enthusiasm and change within these communities and decided to fund a water protection program in the target area. They brought in $15 million to buy drilling equipment and hire all the local community health workers that had been previously trained through the community engagement program. Over several years, water protection projects were developed. Funding support ended and the nonprofit moved on to other project areas. The equipment quickly fell into disrepair since there were inadequate local resources to maintain this sophisticated equipment. All the health parameters deteriorated to prior levels. Community leadership eventually reinstituted their community engagement program. This was difficult, since the community health workers had become accustomed to large salaries. Eventually, the program revived, and health parameters rebounded. Community leadership recognized the threat of external funding and decided they would never again let well-meaning external programs take over the control and priorities of their community health program. They would still apply for grants, but only those that fit community priorities and supported community control. Remember that coalition building is not the same as community engagement, but can be a part of community engagement if the coalition's agenda supports community priorities. I am generally skeptical of coalitions and their agendas if funded by external sources. Next is the relationship between cultural beliefs and intolerance. Coalition members often have different sets of beliefs and values representing different organizational cultures or subcultures. Every culture believes that the way they think, feel, and believe is the way to think, feel, and believe. Anyone or group that differs from their beliefs is obviously wrong. There is a universal tendency to judge other cultures based on one's own cultural beliefs. This thinking leads to intolerance and has likely been the cause of much of the world's conflict throughout history, and if not managed well, the source of many coalition failures. In coalition building, as in general community engagement, a facilitator must encourage tolerance and also be careful not to impose his or her cultural bias on other cultures or subcultures represented in the group. Coalition building is about finding common ground around similarities, not exacerbating divisions based on different beliefs and values. It's not always easy to keep coalition members focused on similarities and common goals versus obvious differences. So a coalition facilitator must take care not to impose his or her cultural bias into the coalition building process. Yet the facilitator must understand that the cultural beliefs and values of coalition groups will deeply influence the process of coalition engagement, and that effective coalition engagement requires an understanding of the culture and subcultures of coalition members. It's also important to understand that the same diversity that causes conflict is an incredible source of energy, creativity, and innovation to solve difficult coalition problems. Cultural behaviors are the result of deeper influences as diagrammed. It all starts at the center with worldview. Worldview can be defined as a culture's deep beliefs in four main categories: self, or beliefs regarding human beings, beliefs about nature, the supernatural, and time, past, present, and future. It's from these deep beliefs or worldview that cultures build their ologies, aggregates of beliefs like ideology or philosophy of life, and cosmology, or where everything comes from, etc. From these deep beliefs, values are formed, the things deemed important in life. It's upon the deep beliefs and values that institutions are built, like governance, education systems, marriage, the running of businesses, legal systems, etc. Finally, all of these deeper layers emerge as behaviors and artifacts. That's why archaeologists can study the things a culture or society made, like art, utensils, etc., and develop a relatively clear concept of what that culture or society believed. Cultural communications experts counsel that if public health desires permanent changes in risky behaviors of a culture or society, that the underlying beliefs and values that drive those risky behaviors must be changed. This is a major premise of community engagement and is wise counsel for a facilitator of coalitions, since much health coalition work seeks to address risky behaviors associated with unhealthy beliefs and values. Let's briefly touch on the role of cross-cultural communications in coalition building. Giesler described three approaches to communicating between worldviews expressing significant differences of beliefs and values. One, the source of a message requires a respondent or recipient of a message to lay aside their worldview and see things through the worldview lens of the source. Two, The source and respondent seek to meet halfway, or exchange one lens each from their worldview glasses and try to see through the lens of both worldviews at the same time. 3. The source temporarily adopts the worldview lens of the respondent. The first option doesn't work well, since the respondent already feels that the way they view the world is the correct view. Why would they want to see things through the worldview lens of the source? The second option doesn't work since it results in significant distortion and confusion for both the source and respondent. That would be like two individuals with glasses who have different refractions, exchanging one lens each. A person with those discrepant lenses would likely not be functional. The third option is the only one that practically works. This option is not easy or perfect, but is possible if coalition participants are willing to try to see things through the eyes of the other partners and persist in the attempt. This approach helps develop tolerance and should be encouraged by the coalition facilitator. Differing worldviews must be seriously considered when facilitating coalition building. As mentioned previously, all cultures automatically judge other cultures that have different beliefs and values. That judgment can drive a wedge between coalition partners. Fostering and encouraging tolerance of differing worldviews is critical and extremely important for public health leaders, facilitators, and coalition members. There will be clashes of beliefs and values in coalition building. Next is building cross-cultural cohesion. A coalition facilitator must build adequate coalition cohesion that will weather the inevitable conflicts of differing beliefs and values. Coalitions coalesce around common goals and must identify how the group will address those goals through a robust planning process. Planning is essentially the time that coalitions get to know each other, define their boundaries and mission, develop a strategy, identify group norms and values, and develop specific tactics or what each partner is to do. Effective strategies are dependent on accurate and current community health data. Community health assessments are an important source of information to inform community coalition planning. Community coalition activities can also be a major part of a comprehensive community health strategy, step 8 on this list. 10 steps have been suggested for effective community health assessments, adapted from the Healthy People 2010 toolkit, including 1. Establish an assessment team. 2. Identify and secure resources. 3. Identify and engage community partners. 4. Collect and analyze and present data. 5. Set health priorities. 6. Clarify issues. 7. Set goals and measure progress. 8. Choose a strategy. 9. Develop a community health assessment document. 10. Manage and sustain the process. Community health assessment is covered in more detail in other sessions of the North Dakota Public Health Training Network. After planning, it's time to implement. Conflict of coalition members' beliefs and values may be seen during the planning stage, but often is exacerbated during implementation when coalition activities take place. Tuckman described 5 stages of small team development that also applies to coalitions: forming, storming, norming, performing, and adjourning. Stage 1 is forming, where team members get to know each other and plan. Members are generally polite with each other in the forming stage, and interactions can be somewhat stilted, artificial, and awkward. This would be seen during the planning stage of coalition building. The implementation stage of coalition building is associated with the storming, norming, and performing stages of Tuckman. Stage 2 is storming. Storming is frequently associated with enhanced conflict as members move beyond the politeness of the forming stage and try to influence team norms, roles, and procedures, often based on the cultural beliefs, values, institutions, and behaviors members bring with them. Stage 3 is norming and is associated with the development of a relationship strength and trust, member cohesion, team agreements around member roles, expectations, and the team's decision-making process to accomplish the assignment or purpose of the group. The coalition facilitator should allow adequate time for members to develop relationship strength and trust. Encouraging active listening and creating opportunities for coalition members to socially interact in a neutral space can help foster relationships and trust. This is particularly important if the coalition will address complex adaptive problems. Moving a coalition to address adaptive problems before they have appropriate relationship strength and trust may result in failure. Let's briefly discuss cultural change and resistance. Consider cultures and communities as organisms, living in a perpetually changing environment, needing to flex and adapt to those changes for their survival and health. Effective coalitions function as community change agents. Even though essential, change is often uncomfortable and resisted, even though that change will lead to improved health and wellness of the community. So expect resistance and tension in coalition building within the group due to clashes of intergroup beliefs and values, and also within the community as coalition activities move forward toward cultural change. The most resistance to change occurs when targeting the areas of deep beliefs and values. An extremely important point is that external individuals and experts can't change a community's beliefs and values no matter how hard they try. Only members of the target community or culture have the right and ability to change their culture. External experts, like public health leaders, can only facilitate communities and community organizations within coalitions in discussions around their beliefs and values that drive risky behaviors. This underlines the importance of coalitions that contain strong organizations from the target community. This may seem like a no-brainer, but unfortunately doesn't always happen. Charles Kraft states that community or cultural change, the goal of most health coalitions, is associated with 5 major steps. 1. Understand the cultural viewpoint of the element needing to be changed. A facilitator must understand the culture of the community as previously discussed. 2. Encourage essential worldview, beliefs, and values versus just a peripheral behavioral change. 3. Assure community leader support. If coalition groups or organizations are appropriately chosen, they will likely represent key formal and informal community leaders. 4. Engage community organizations. This is done through effective coalitions. 5. Practice patience. Patience is a problem in our fast-paced world. Patience to move at the speed of the community and coalition is essential. Next is the concept of perceived and real needs. Communities and coalition members will engage in issues they perceive as important. These perceived needs may or may not reflect the real needs as perceived by other external experts. Yet these are the issues coalition members will own and address. Coalition building is facilitating coalition members to own the problems and solutions of their community. It's facilitation of a process of problem solving, not just accomplishing a project. Commonly, coalitions will eventually address the real needs perceived by external experts, but within their priority and time frame. As emphasized by Kraft, patience to move at the pace of the coalition and community is essential. A facilitator can help a coalition identify and prioritize their perceived needs by utilizing a variety of nominal group processes, like the snow card technique, road to health, etc. During the coalition planning process, other sources of information can be utilized to help inform discussions around priorities, like the Behavioral Risk Factor Surveillance Survey, BRFIS, Youth Risk Behavior Survey, YRBS, local surveys, national reports, reports of interest groups like the American Heart Association, American Lung Association, Cystic Fibrosis Foundation, etc. Minkler suggested that community organizing engagement, including coalition activities, must recognize that in order to change, we all must feel a need for change, a perceived need, and that we are more likely to do so when we are involved in group learning and decision making, part of a facilitated coalition building. An important element of community organizing is helping communities and coalitions look at the root causes of problems while at the same time selecting issues that are winnable, simple, and specific, and that can unite members of the group, involve them in achieving a solution, and further build the community. The last community engagement concept I'd like to address is the importance of using group participatory techniques. Group participatory techniques are useful to foster coalition member ownership of their community's problems and solutions. The technique I've used most is Lepsis. There are also other techniques that utilize similar participatory concepts to encourage participant engagement, including open space technology, Foo Camp, Bar Camp, and Design Sprint. Design Sprint was pioneered by Google Ventures to stimulate design thinking. One of the shortcomings of open space technology is that it doesn't engage introverts very well. So other techniques are often used along with open space technology to enhance engaging those individuals. Lepsis, when facilitated appropriately, engages all participants. That's one of the reasons I have used this technique extensively. All of these techniques requires a well-trained facilitator to lead the group process. LEPSA is an acronym. LE stands for learner-centered, P for problem posing, S for self-discovery, and A for action-oriented. Some facilitators of faith-oriented groups use the acronym LEPSIS, where the last S stands for the spiritual component. In many cultures, the supernatural worldview is extremely important and has exceptional ability to influence community beliefs, values, and behaviors. This method is useful for relatively small groups of 10 to 20 individuals to enhance participant engagement. The facilitator's role in Lepsis is to draw out information from the group to foster ownership of the ideas and provide key knowledge that is not readily forthcoming. Further discussion of Lepsis is covered in other sessions of the North Dakota Public Health Training Network. The literature suggests the following about effective coalitions. 1. Coalitions require that each party believes it needs the help of other coalition members. Coalition members must be codependent on one another to accomplish their organization's goals. 2. The goals and perspectives of the members of a coalition will not all be shared. However, An effective coalition requires sufficient common ground so parties can agree on a coalition mission, set of policies and strategies, group norms and values, and tactics. 3. Coalitions require continuous and often delicate negotiation among their participants due to different beliefs, values, and agendas. The neutral facilitator must often employ negotiation techniques to keep the coalition intact. As mentioned previously, relationship strength and trust between members is essential for coalition cohesion during the inevitable times of stress and tension due to the inherent differences between coalition partners. 4. The distribution of power and benefits among the members of a coalition is an ongoing concern. All members need to believe that over time they are receiving benefits that are at least comparable to their contributions. The effectiveness of coalitions can be evaluated on two distinct outcomes. 1. How well the members work together. This again will depend on the relationship strength and trust between members and the facilitator's skill at negotiation. 2. What kinds of community level changes they bring about. There are three broad categories of evaluation. Formative, that provides data and analysis to plan a program. Process, that assesses participation metrics. And outcome, or the coalition's effectiveness at achieving the goals or mission of the group. How well the members work together would be a process evaluation where the impact on community changes would most likely be an outcome evaluation. Zaycox and Edwards suggested 6 factors that determine coalition effectiveness, including 1. Formalization of rules and procedures. The coalition must establish a mission, strategies, including goals and objectives, the norms and values that define how the group will work together, and tactics. Those rules would include how decisions will be made and the rules of engagement or coalition ground rules. Let's consider the decision-making process. Decision-making is frequently a cause of coalition conflict. Decision rules need to be explicit and agreed upon by the group, like whether decisions will be made by a simple majority, 2/3, 100% concurrence, etc. If the coalition leadership style is autocratic, the leader or small group of leaders will be making all final decisions. This slide lists a few decision-related effects that are relatively common and should be avoided. The free rider effect was defined by Albanese and Van Fleet in 1985. These are people who obtained coalition benefits, gladly accepting credit for accomplishments, yet marginally participate. Many times, these individuals support decisions that promote their self-interest over that of the coalition. The coalition leader needs to identify free rider incentives and neutralize them. If not addressed, free riders can undermine coalition activities, morale, and cohesion. The groupthink effect was described by Janus in 1972. Groupthink occurs when the desire for harmony and consensus trumps rational and critical thinking. In this situation, coalitions fail to analyze a problem adequately and as a result prematurely decide on a less than adequate solution. All potential solutions should be critically analyzed before a final decision is made. Sometimes groupthink arises when an individual with a strong, forceful personality dominates coalition discussions. The leader can avoid this by reinforcing group rules and encouraging and even pushing the group for multiple options and opinions, including those that may be controversial. Let's review some common ground rules for meetings. Without ground rules, meetings can deteriorate into divisive wars or allow forceful individuals to dominate discussions. Common rules include One person speaks at a time and must be recognized by the facilitator before speaking. Commitment to listen to one another. Try to understand the other's point of view before responding, attempting to see things through the worldview lens of the other person. Talk directly with the person with whom there is a concern. Avoid side group gossip or alliance building. Allow expressions of dissent, respecting each person's opinion. Attack issues and problems, not people, and describe how conflicts will be addressed. These ground rules should be reviewed by the facilitator at the beginning of each meeting and whenever necessary to control emotions, maintain civility, control dominating personalities, and keep the coalition focused on the task or goal. Avoid paralysis by analysis. There will always be more data that can be collected and analyzed. Some coalitions, for various reasons, feel unwilling or unable to make a decision and will shift activities from gathering enough data to make an informed decision to accomplish the task to a new coalition goal of perpetually gathering and analyzing data. The coalition gets mired in overly detailed perfection in data gathering and analysis, trying to cross every T and dot every I. High-performing organizations, teams, and coalitions gather just enough data and analysis to make a good decision and quickly move on to implementation. Coalition members must identify the data and analysis threshold needed to make a good, informed decision to accomplish the task. Don't become a victim of the paralysis by analysis. Gather and analyze enough data to meet situational needs. Number 2 is leadership style. Rensis-Likert described a leadership continuum from autocratic to benevolent, consultative, and participative or democratic. An autocratic leader has complete authority and the followers obey the instructions of the leader without questioning. Benevolent leadership creates observable benefits, actions, or results for the common good. Benevolent leaders may be autocratic, consultative, or democratic as well. Consultative leaders attempt to involve people who have problems in seeking ideas for a solution. Team building is a prime target of consultative leadership. Participative or democratic leaders pursue decision-making as a shared process where the views of a team or group are valued and contribute to the vision, goals, and decisions that are made. Some management experts add that leaders may use these different styles based on the management situation, called the contingency or situational theory. Sometimes an authoritarian approach may be most effective, whereas in other situations the benevolent, consultative, or democratic styles would be most appropriate. Leadership styles that are generally associated with effective coalitions in Western societies are the consultative, democratic, and benevolent styles versus the authoritarian style. The third factor of coalition effectiveness is participation of members. Participation is dependent on the coalition meeting the perceived needs of the members and utilizing appropriate participatory techniques like lepsis. 4. Diversity of membership. Coalition members need to learn from each other to fully understand the innovative and creative opportunities and possibilities to tackle complex problems. This means that members should bring a variety of skills, competencies, and experience to the team. If everyone has the same background, there will be no or minimal coalition learning. So adequate coalition diversity is important for vibrant learning to ultimately identify creative solutions to complex adaptive problems. Learning coalitions with their varied backgrounds are also more sensitive to the variety of subtle signs associated with external stakeholders and the environment. 5. Collaboration. Groups will only participate and collaborate significantly on issues they feel are important for their organizations. 6. Group cohesion. Once again, cohesion is dependent on adequate relationship strength and trust. Spending adequate time to develop and maintain relationships and trust is essential for effective coalitions. In 2008, Integrated Healthcare Strategies and the Governance Institute developed a list of practices that apply to boards and top-performing organized groups like coalitions. This included 3 group duties and 6 core responsibilities. The 3 prime duties include: 1. Duty of care. Requires that members have knowledge of all reasonable, available, and pertinent information before taking action. Members must act in good faith and in a manner he or she reasonably believes to be in the best interest of the coalition. 2. Duty of loyalty. Requires that members discharge their duties unselfishly in a manner designed to benefit the coalition and not a member personally. It incorporates the duty to disclose situations that may present a potential for conflict with the mission, as well as a duty to avoid competition with the coalition. 3. Duty of obedience. Requires that members ensure that the coalition's decisions and activities adhere to its fundamental purpose and mission. This slide lists the 6 core responsibilities of a coalition, including 1. Financial oversight if financial resources are funneled through the coalition. 2. Quality oversight. Effective coalitions must utilize a quality improvement cycle, including a planning, implementation, and evaluation process. 3. Setting strategic direction, part of the planning stage. 4. Develop a self-assessment and goal-setting process. This would include the initial formative evaluation process to help the coalition develop an effective plan. This would also include the evaluation part of the cycle that informs further planning and coalition strategic improvement. 5. Management oversight of coalition activities. And 6. Advocacy as it applies to coalition work. Advocacy is an extremely important part of many public health coalitions and is covered in more detail in other sessions of the North Dakota Public Health Training Network. These next 2 slides from the National Institute of Health book, Principles of Community Engagement, list 7 items considered necessary for engagement, including effective coalition building, to occur. 1. Go to the community, establish relationships, build trust, work with the formal and informal leadership, horizontal communicators, and seek commitment from community organizations, not structures, and leaders to create processes for mobilizing the community. Community structures exist to resist change. Community organizations exist to influence community change. It's not always possible to determine a community structure from an organization by its name. It's often necessary to observe what it does or doesn't do in the community to determine whether it's a structure or an organization. Work with organizations, not structures, in coalitions. 2. Remember and accept that collective self-determination is the responsibility and right of all people in a community. No external entity should assume it can bestow on a community the power to act in its own self-interest. The community holds all the cards. The role of a community coalition facilitator is to facilitate community discussions to foster ownership of their problems and solutions. This is what effective coalition building and community engagement does. Much of what is done in the name of engagement and coalition building is really community coercion. Other important items to consider include 3. Partnering with the community is necessary to create change and improve health. This concept underlines the importance of true collaboration and partnerships, strongly recommended by the Institute of Medicine in 2012. 4. All aspects of community engagement must be recognized and respect the diversity of the community for effective community coalition building. Awareness of the various cultures and subcultures of a community and other factors affecting diversity must be paramount in planning, designing, and implementing approaches. 5. Community engagement and effective coalition building can only be sustained by identifying and mobilizing community assets and strengths, and by developing the community's capacity and resources to make decisions and take action. 6. Organizations that wish to engage a community, as well as individuals seeking to effect change, must be prepared to release control of actions or interventions to the community and their coalitions, and be flexible enough to meet its changing needs. 7. Community collaboration requires long-term commitment by the engaging organization and its partners. Once again, community coalition building, like community engagement, requires patience to move at the pace of the community. Public health activities are often defined as promoting, protecting, improving, and when necessary, restoring the health of individuals, groups, or the total population. This slide lists the 10 essential public health services or domains that were described in 1994 by the Public Health Functions Steering Committee. 1. Monitor health status to identify community health problems. 2. Diagnose and investigate health problems and health hazards in the community. 3. Inform, educate, and empower people about health issues. 4. Mobilize community partnerships to identify and solve health problems. 5. Develop policies and plans that support individual and community health efforts. 6. Enforce laws and regulations that protect health and ensure safety. 7. Link people to needed personal health services and assure the provision of health care when otherwise unavailable. 8. Assure a competent public health and personal health care workforce. 9. Evaluate effectiveness, accessibility, and quality of personal and population-based health services. 10. Research for new insights and innovative solutions to health problems. The essential service of mobilizing community partnerships is all about community engagement and effective coalition building at the community level. In summary, coalition building is often a significant part of engaging communities and is a practical way to integrate health stakeholders. Understanding the beliefs and values of partners is essential for effective coalition facilitation. Relationship strength and trust is key for partner engagement and resilience. Coalition building requires patience. Participatory techniques foster coalition ownership of problems and the identification of innovative solutions. Developing coalitions that manifest the 6 factors of coalition effectiveness enhances coalition success.